Thank you for coming. It's the last kind of session of a long meeting. I missed about half of it. I came late, so it was less time for me. So we'll talk this session for about 25 minutes about insect sting allergy. You all have seen it. It's a relatively common condition. We all see it. But I'll try to put kind of summarize some of the ideas about the pathogenesis of the condition and also the treatments. So insect sting allergy is really primary reactions to Hymenoptera. So there are different kinds of Hymenoptera, and we'll talk a little about it later on. It affects a significant part of the population. There are different studies. The numbers are not very accurate between studies. There are big differences. But it's also a very common kind of occupational disease. So in beekeepers, a significant number, up to 40% of beekeepers, develop severe reactions from being stung by bees. It has a high impact on quality of life. It causes life-threatening reactions, so it causes anaphylaxis in certain percent of these people. And appropriate diagnosis and treatment is very important, as we all know. So these are the different Hymenoptera that we talk about. So they are the bees, honeybee and bumblebee. They are the vespids. And there are a few different categories of the vespids. And these can vary also depending on where you work. So they're different in North America, where I work. There is different in Europe. And there might be some differences also in this part of the world. I'm not sure about that. And also about ants. And I will not talk much about ants, but the second talk today, it's about it's about allergy to some ants. That I guess it happens in this part of the world. So just very quickly about how allergic sensitization works. It's a very general kind of scheme that I will try to talk about. So somebody gets a bee sting, so the antigen is picked up by Langerhans cells in the skin, if it's in the epidermis, or antigen-presenting cells, the dendritic cells in the dermis. It's presented to T cells, and that's how we develop Th2 cells. And these are the classic cells that we see in all kinds of allergy, and it's the same thing also in bee sting allergy. These cells release different cytokines. These cytokines activate the B cells to generate IgE. And this IgE binds to the mast cells. And when in the re-exposure to an allergen, our mast cells, these antigens, they are activated, release histamine and a lot of other mediators, and how a lot of the symptoms of anaphylaxis happen or other allergic reactions happen. So in general, our immune system has a decision to make when it sees something like a venom to an insect venom. It can develop allergy. It can, in some cases, we have non-detectable immune response. And what that means usually is that we develop a small number of Th2 cells, of CD4 Th2 cells, so cells that could mediate allergy, but not enough for symptoms, and could generate also a tolerogenic response. And earlier today, in the section about the hygiene hypothesis, there was some discussion about the different T regulatory cells and how these can affect the immune response. So T regulatory cells can have a lot of effects. They can downregulate the effects of both Th1 and Th2 cells, so they can downregulate the effects of the cells that cause allergy. They can suppress also IgE production, and they can facilitate the generation of IgG, that is the type of antibody that it's kind of associated often with immunotherapy that we know about, and also with protective responses. But also can have also direct effects on the effector cells. So the Treg cells can also downregulate the effect of a lot of the effector cells. Natural stings and occupational exposure can do the same thing. So a lot of the people that work with bees actually become tolerant themselves through development of Tregs through the exposure to this venom. And there has been some really elegant work, probably the best work in human system, trying to identify how this immune system has developed through studies on beekeepers, mostly in Switzerland. So what are the types of reaction that we develop to insect stings? So there is a normal reaction. Everybody has an immediate, local, transient reaction, mostly with pain, swelling, inflammation. Then we have large local reaction when we start talking about things that an allergist might see. More late, prolonged, progressive reactions. We have the systemic reactions, and then we can have also other reactions like toxic and serum sickness reactions that I will not talk much about those today. We'll focus more on the large, local, and the systemic reactions. So that's local is a swelling that is big, about more than 10 centimeters, and lasts at least 24 hours. Systemic reactions are the classic IG-mediated reactions that we talk about, and they can involve a lot of organ system, so skin, GI tract, respiratory, cardiovascular system. And in children, the majority of these systemic reactions are mild and restricted to the skin, although obviously children also can get anaphylaxis and severe reactions to bee stings. But in adults, they are more common to get severe reactions when they are stung with bees. Again, the prevalence of this condition is not very clear, not very accurate numbers. So some studies where they kind of identified self-reported people with severe reactions to bee stings give prevalence from 0.3 to 7.5%. So quite wide range, less frequent in kids. And the incidence, obviously, of the most severe reaction, when we have mortality from the reaction, is much lower. So about 0.03 to 0.48 fatalities per million inhabitants per year. So it's quite rare, but still it's a significant problem. Actually, if we take it as a cause of anaphylaxis, in adults it's the second after drug allergy. So in adults, it's much more common to get anaphylaxis from bee sting than get anaphylaxis from foods. Obviously, again, it's different in kids. Kids get a lot of reactions to foods and more frequently get anaphylaxis from foods. So what are kind of risk factors for systemic reactions? First of all, what we all know, most of the people that present with systemic reaction, even with fatal reactions, the majority of these people don't have a known allergy to bee sting before. It can be really your first severe reaction to a bee, could be severe anaphylaxis or even be a fatal reaction. If an adult develops an anaphylactic reaction, then there is a very high risk of developing an anaphylactic reaction again to re-exposure. Studies say between 40 and 60%. And this risk, although it's higher early on after the first bee sting, it can last for a long time. So even 10 years or 20 years after your anaphylactic reaction to a bee sting, your chance of developing another anaphylactic reaction is quite high, 20 to 30%. So it's a severe problem, it's a significant problem, and identifying the people that actually get anaphylaxis to bee stings and doing something about it is important to prevent these severe reactions. So what confers increased risk for systemic reaction? And again, they are not very good studies. It's a rare condition. In many cases, we don't even identify all these patients that have an anaphylactic reaction to bee sting. So kind of studies, observational studies mostly over the year, they've shown that older men, and older, over 40, I'm over 40, so I don't offend anybody else by calling us older men, with cardiovascular disease and a previous history of Hymenoptera, still allergy is the most, they have higher risk than the rest of the population. Use of certain medications that have also increased risk for anaphylaxis. It's the same thing here, we're talking about anaphylaxis. Stings in the head or neck can have more common, more severe symptoms. And the big problem in all these reactions, the same thing that we see also in anaphylaxis, is that delayed or lack of use of adrenaline to treat the symptoms, or epinephrine to treat the symptoms, it's one of the big problems. And I will not talk much about mastocytosis, but mastocytosis is a condition where we have high burden of mast cells, and people's mast cells are very sensitive to activation, seem to get a lot of reactions with bee sting and have more severe reactions. So how do we diagnose it? Like a lot of things in allergy, really, a good history is the most important first step to make a diagnosis. Diagnostic tests are important, but if we don't have a good history and we don't have high level of suspicion when we do the diagnostic test, very often the diagnostic tests we do are not as useful. Classify the reaction. Again, the type of reaction will kind of determine what treatment we'll suggest and where we will go from there. And then we do skin test. So skin test with venoms can identify the particular Hymenoptera that somebody might be sensitive to. So you find venom-specific IgE antibodies. And also can tell us which one is responsible, because most of the patients, when they show up in the clinic, they cannot really tell us what bee they were stung with. And even myself, at least, even when they describe the bee to me, I'm not very good at identifying what kind of bee it was. So these tests can help us kind of identify which bee might be responsible for the symptoms. We can do in vitro tests, so we can measure specific IgE antibodies in the serum with kind of what we generally call rust tests, although most of them are not rust anymore, obviously. But these have their uses, and they could be the next step after we do skin tests, especially if we have a skin test negative person, because there is a small number of people we can pick them up with in vitro tests after they have a negative skin test. One of the problems, and I will not spend too much time because it came up also earlier today when we were talking about diagnosis with recombinant antigens and kind of component resolved diagnosis, is how do we identify double sensitivities? So somebody comes, had one sting in their life, they had an anaphylactic reaction, we do skin tests and they are positive to two bees, two kinds of bees. Obviously they reacted to one of them, and we really don't know whether they are sensitive to both of them or there is some cross-reaction. There is cases where there is true double sensitization, but there are also cases where there is cross-reaction between either because the allergens are very similar, for example, the hyaluronidases can be very similar, or sometimes there is Ig cross-reactive to carbohydrate determinants. So a lot of these allergens in bees have carbohydrates. They are proteins with carbohydrate moieties on them. And some of the Igs against these carbohydrates, and this Ig is not actually associated with anaphylactic reactions. And there is also significant cross-reactivity between different kinds of insects. So, for example, the first difference is that across the world, the insects are very different. They might belong to the same family, but they could be different members of the family. Honeybees across the world kind of cross-react a lot, so they are very similar. But there are also similarities between honeybees and bumblebees, or the cross-reactivity between different vespids. So it's important to know all these things and be able to identify what is the specific bee that caused the symptom. And we talked, as I said, we had the talk earlier today about using recombinant antigens that might give us an idea of what's the likelihood that somebody is sensitized to both kinds of bees or one bee. And this was one recent study where they tried to expand a little more and see what's the best option. And when they combined these basophil activation assays with recombinant antigens and also deplete the serum from the carbohydrate specific Ig and then measuring Ig to recombinant antigens, they found that that's the best way to identify the people that are cross-reactive versus the people that are sensitive to both allergens. Obviously, that's something that we cannot do in general practice these days. I mean, we're probably a long way from doing basophil activation assays as a routine test for the patients because they're not easy assays to do. But it is where the future of this area is probably going, where hopefully one day we'll have better ways to really identify what the specific allergen that somebody is sensitive to. Treatment, again, I mean, there are some class kind of basic ideas that we have to follow. Obviously, we have to advise the patient to minimize exposure to further stings. I mean, the best treatment is the prevention. And if we knew that somebody will never get stung with a bee again, then we almost don't have to do anything. But it's impossible, obviously, to decrease the risk to zero, and that's why we need to do also other things. Giving people epinephrine, and I've done that. I have it half the time epinephrine and half adrenaline. I don't know. So self-administering epinephrine to people, it's very important because it will be the first line treatment if they develop anaphylaxis. And we all know that venom in immunotherapy in selected people is the treatment of choice. And we had also in this meeting a couple of discussions about immunotherapy, and there was a big kind of controversy yesterday, if you want that. But I think this area is the one area that there is really no kind of dissenting opinion. I think everybody believes that immunotherapy for bee venom is indicated and is very effective. There are different schedules of immunotherapy, and different people for different reasons use different schedules. For example, during my training, I worked in an army hospital in the US where I did my training, and we used most of the times ultra-rush regimens because we would bring soldiers from wherever unit they were at, keep them for a day in the hospital, do ultra-rush regimen, and then send them back, and thinking that over the next couple of days they will be protected, or very soon they will be protected. Most of the times, at least nowadays in my clinic, I do the conventional regimens. They have lower risk of side effects, but they take longer time to do. It is an effective treatment. Studies with this treatment started quite early, from 78. The first New England Journal of Medicine was in 78. And all the studies show that there is a very high degree of protection. 83 to 95% protection of people that are on immunotherapy in different studies. And the good thing is we heard also for the rest of the immunotherapy. Immunotherapy seems to have immunomodulatory effects, so the effect of immunotherapy remains even after we stop the treatment. And it's clear also in B venom immunotherapy that the effect is long-lasting after the treatment. You discontinue the treatment. Although the exact duration of how long this thing lasts is not very clear. So just I'll show you, last year there was a Cochrane database meta-analysis of the studies for venom immunotherapy. And they included studies for ant, bee, and wasp immunotherapy in children and adults, people that had a previous systemic or large local reaction. So they went through a lot of papers. They identified around 30 papers, if I remember correctly. There were only 7 papers that they included, and Cochrane databases are kind of restricted sometimes. They want really very high-quality studies, and that's a good thing because the data are more valid. But then we end up with very small numbers when we do that because a lot of the other studies around get to be kind of rejected from the study. Most of the studies were rejected because they were not placebo-controlled, and it's very difficult to kind of understand the risk of something if you don't have a placebo group. So most of them were subcutaneous immunotherapy, and that's what we do. There was one study also that included also sublingual immunotherapy for venom. And as the authors say, there was a high risk of bias because a lot of these studies, they were not blinded. So the researchers knew what group the patient was on. So what did the study show? So when they studied any systemic reaction to an insect sting, and studied it either to 6 weeks and up to 4 years after the initiation of immunotherapy, there was significant decrease of the risk. So the relative risk ratio was down to 0.1 with a confidence interval from 0.03 to 0.28. So really protects from systemic reaction to insect stings. When they also studied large local reaction, there was also a significant protection from large local reactions. Again, relative risk down to about 40%. And also when they studied quality of life, and that was less studies, there were 2 studies that had quality of life, but there was a 1.2 points higher quality of life in people that received immunotherapy versus those that did not receive immunotherapy. Something that in the scale they used is clinically significant. And that's because people are less worried about it. They think they are protected. They know more also what to do in cases that something happens, so they really increase their quality of life. And in this kind of review, they have, in the end, what's interesting, kind of give some ideas of what should be done to really understand how the disease works and improve what we can do about the disease. So we should identify the patient groups who benefit most from the treatment and also the optimal treatment duration. There are some guidelines, there are some ideas of what we should do, but we really don't know what's the best way to do it. There haven't been enough studies. There haven't been studies that have compared different duration of treatment to really know what's the optimal. Also, quality of life and health economics outcomes would be very important. I mean, it's a new thing, and now all the studies these days actually measure these outcomes because we think they are important, both for the patient, if we increase their quality of life, but also for the healthcare system, especially at a time where around the world there are a lot of economic problems, and kind of understanding how much we should spend to improve people's quality of life is important to know if it's worth it. And also future trials should investigate modes of immunotherapy, which carry a reduced risk of systemic reactions. So sublingual immunotherapy, we heard today a long talk and discussion about sublingual immunotherapy. It's a very kind of interesting idea. It's not just an idea anymore. It's a very interesting treatment for now. I mean, it has very good data that it works. Although I train in North America, I've never used sublingual immunotherapy, and now that it's approved in Canada for about a year, I'm kind of trying to learn how to use it. But seeing all the studies and all the big experience, long experience that has been in Europe, it's a very interesting idea, and B venom immunotherapy could be also the next step to use it more regularly. Not a lot of ideas of when the immunotherapy is effective, and I put one study, I will just discuss it very quickly. I mean, we start somebody on immunotherapy, we don't know if they are protected or if they go the right direction until they get a bee sting and we know they are protected or not. So this study, they did whole genome expression. So they got blood, they did microarrays for RNA, so they find all the genes that are transcribed in their blood. And they found that some people, when they start the immunotherapy, they have a lot of changes from before the immunotherapy in this expression. And then if you take people that you stop the immunotherapy and you know they are protected, they also have changes, but they are much less than the people that are on active immunotherapy. So there are some changes that remain long-term, so maybe these changes can be measured early on, and maybe they can predict who is protected and who we can stop immunotherapy. And studies like that is what we need, I think, to be able to put more evidence behind how long we do immunotherapy, what protocol is the best with immunotherapy, when do we stop it, and all these questions. So what are the predictors of systemic reactions during immunotherapy? So again, that's an observational prospective study, about 608 patients, so a large number of patients for this kind of studies. They measured a lot of things in these patients. So what came out of all this stuff? So therapy with honeybee seems to be more likely to cause systemic reactions than therapy with vespid. And that, obviously, we treat them with what they are sensitive to, so we don't make this decision. But people that need therapy for honeybee, they are more likely to have side effects, so we have to be more careful. Presence of venom-specific IG in the serum, so the more of that can increase the risk of developing symptoms. The type of the regimen, as we said, the ultra-rush regimens have higher risk of side effects than the more conventional regimens. The interval between the most recent sting reaction and immunotherapy, so the closer it is to the sting reaction, the more likely to develop severe side effects. And also, the last one that they saw was that basal tryptase level in the serum seemed to be associated also with increased risk of reactions. So they suggested in the paper that maybe it's a good idea to measure tryptase levels on everyone, and maybe we have to be more careful for people that have elevated tryptase levels to begin with. And what's interesting in the tryptase level is that the tryptase level had increased risk only for vespid immunotherapy, not for honeybee immunotherapy. So again, maybe there are subgroups of patients and there are specific categories where we can understand how these things work and be able to prevent some of these reactions. I will finish with a little thing going back to mast cells and mastocytosis. So we know that mastocytosis is considered a condition that predisposes to severe reaction to insect stings. But it's the other way around also. If somebody has an insect sting reaction, is this a mast cell disease? So there was a study where they got close to 400 subjects with systemic reactions to insect stings, and they measured in all of them basal tryptase levels. And if the tryptase level was high, even though it was not as high to actually trigger directly an evaluation for mastocytosis, they did the classic mastocytosis evaluation. So they did bone marrow biopsies, histology, cytology in the bone marrow biopsy, flow cytometry, and also check these KIT mutations that we know are associated with mastocytosis. So what did they find? So out of the 379 patients, 44 had high tryptase levels. So it's about 10% of the patients that have high tryptase levels. Out of those 44, 31 have anaphylaxis. And out of those 44, they did bone marrow analysis and all the workup in 34 patients. And actually, it's very interesting after that. Out of those 34 patients, 21, actually they were able to diagnose them with indolent systemic mastocytosis. So they had mastocytosis. It was not very severe. It hadn't manifested itself before, but they had the disease. And another 9 had what it's kind of this new entity over the last years, monoclonal mast cell activation syndrome. So condition where there is some disorder in the mast cells, but not enough, but the patient does not fulfill the criteria for systemic mastocytosis. And actually what's even more interesting is that all the subjects that had anaphylaxis, so these 31 patients that had anaphylaxis, all of them were diagnosed with a mast cell disorder. So it almost from this study, if it's true, looks like that if you have an anaphylactic reaction to bee sting, almost we have to look for mast cell disorders, and maybe that's the reason why these patients develop anaphylaxis and the rest of the sensitive people have less severe reactions to bee stings. So in conclusion, insect venom allergy is not an uncommon condition. Appropriate diagnosis and treatment can decrease adverse effect of insect stings and improve patients' quality of life. And as we talked before, it is one of the clear indications for allergen immunotherapy for these patients. Thank you for your attention.
Thank you, Dr. Vilogoftis, for this interesting presentation. We will keep the question to the end of the session and move directly to the second presentation with Dr. Deep. My colleague will present Dr. Deep for those who don't know him.
Thank you. Voilà, je vous présente Dr. Deep, qui est donc allergologue. Il a fait ses études de médecine générale et d'allergologie en France. Puis, donc, il est allergologue, chef de service d'allergologie à l'hôpital Tawam aux Émirats Arabes Unis entre 88 et 96. Puis, donc, il est fondateur et le premier président de la Société Libanaise d'Allergologie et d'Immunologie de 1997 à 1999. Donc, il est l'auteur de 15 publications et d'une cinquantaine de présentations dans des congrès de médicaux. Donc, Dr. Deep, à vous.
Merci, doctora Fatima. Nous ne sommes pas nombreux. C'est peut-être pas seulement dû à la longueur de ce congrès, mais aussi ce qui arrive quand ce n'est pas sponsorisé par les compagnies pharmaceutiques. Donc, le sujet, c'est une histoire que je vais vous raconter, qui s'est passée il y a une vingtaine d'années, mais en fait, elle est toujours d'actualité. Ça ne marche pas, là? Ah. Ici, là? Ah, ça ne marche pas, il m'a dit. Ah. Ne marche pas celui-là? Non? Ah, d'accord, ça va, ça va. Je ferai avec ça. معلش مخلي انا تمشيها خلاص مشيها بيها بشتغل الليزر بس يلا معلش بشتغلها ok la présentation un peu plus détaillée viendra plus tard mais notez déjà le dard voilà le dard donc c'est une piqûre et non pas une morsure parce qu'on ne savait pas trop au début, s'agit-il de l'une ou de l'autre. À la fin des années 80, quand j'ai été nommé à l'hôpital Tawam, le directeur médical de cet hôpital, le docteur Hutchins, me dit « Il y a une fourmi ici qui fait des problèmes. Et ce serait peut-être bien si vous pouvez faire le point là-dessus. » Une fourmi? Je me dis « Oui, j'avais vaguement entendu parler d'une fourmi américaine. » Mais dans le Golfe, tout ça, ailleurs, je n'avais pas la moindre notion. Donc, il fallait commencer bien par quelque chose. Trouver des malades, leur demander où est cette fourmi pour faire sa connaissance. Coup de peau, à l'hôpital où je travaillais, il y avait plusieurs personnes, peut-être 5, 6, qui présentaient cette allergie, dont la femme d'un collègue. Alors je leur dis, où est cette fourmi? Faites-moi la présentation, qu'on puisse commencer, qu'on tienne le fil. Eh bien, docteur, venez, ici. Quelques mètres après l'entrée de l'hôpital, dans le jardin de l'hôpital, voilà, la voilà. Ici, un nid, ici, là, partout. C'est une fourmi, on reviendra plus tard, qui se trouve partout dans les pays désertiques, on verra. Et même les médias non spécialisés, ça c'est le Khaleej Times, c'est un journal émirati de 91, voilà, il dit fatal ant bite, on ne savait pas trop là, il dit bite, c'est-à-dire morsure, en fait, on aurait dû dire fatal ant sting, enfin c'est pas un journal spécialisé bien sûr, il parle d'une femme victime de cette fourmi. Alors, la localisation de cette fourmi à travers le monde, voilà, ça marche maintenant. Donc, en Afrique tropicale, voilà, ailleurs, sur l'atropique du cancer. On ne sait pas trop en Amérique, peut-être ça existe ou pas, je n'ai pas de données. Mais en Afrique tropicale, c'est sûr, dans la péninsule arabique, et dans le pays particulièrement où j'étais, les Émirats arabes unis, et voilà où j'étais, à Al-Ain, c'est une ville à l'intérieur du pays. Voilà, pour couper un petit entracte. Voilà, donc, une fois la connaissance faite de cette fourmi, il fallait identifier l'espèce. Dans le jardin de ma maison, comme je vous ai dit, c'est une fourmi qui se trouve partout dans le jardin de ma maison. Puisque maintenant je la connais, je ramasse quelques spécimens, je les envoie au British Museum de Natural History. Monsieur Bolton, que je ne connaissais pas, que je ne connais toujours pas, il me répond, c'est un entomologue du British Museum, il me répond, il s'agit, l'espèce s'appelle Pachycandila senearensis. Dans le règne des Hymenoptères, vous avez, le docteur Harry vient de parler des abeilles et des guêpes à droite. Bref, les fourmis, vous avez le règne des fourmis, donc la famille des fourmis, et puis vous avez, ce qui nous intéresse, deux fourmis. Les fourmis américaines, qui s'appellent le fire ant, ou la vraie appellation imported fire ant. Pourquoi imported? Parce qu'elle a été importée du Brésil au XIXe siècle. Donc elle est venue, ce n'est pas une fourmi native des États-Unis, c'est une fourmi qui vient du Brésil par bateau. Et après, ça a fait des enfants et les enfants des enfants. Donc elle fait des problèmes où? Dans les États du Sud, c'est-à-dire Floride, Georgia, Alabama, Mississippi, Louisiana, etc. Et il y a eu des centaines d'articles sur ce sujet. Notre fourmi n'est pas du tout la même, c'est un cousin même lointain, c'est une fourmi d'accord, mais c'est un cousin lointain, donc du Solenopsis, la fourmi américaine, Solenopsis invicta ericheri. Alors, par où commencer l'étude? Donc, on a fait la connaissance de cette fourmi, on l'a identifiée, il fallait maintenant prouver deux choses. Que le problème existe, et non pas seulement de bouche à oreille. Deuxième étape, et surtout, prouver que les réactions systémiques généralisées étaient de nature anaphylactique, c'est-à-dire médiées par les IgE, afin éventuellement de pouvoir fabriquer l'extrait pour le diagnostic et la désensibilisation. Et pour cela, il fallait avoir le support, donc le docteur Hitchens de l'hôpital, donc l'hôpital Tawam, bien sûr, j'ai eu son soutien, et le soutien officiel du ministère de Santé des Émirats. Un petit l'emblème de ce pays, la chasse au faucon, le faucon, l'emblème national. L'étude préliminaire donc a eu lieu en 92, un petit peu avant, enfin ça a été publié dans le Lancet en 92, avec la collaboration de deux collègues de la faculté de médecine des Émirats, Dr Ferguson et Slivik. Dans cette étude, je voulais seulement prouver que le problème existait. Pour ceux qui connaissent l'arabe, bien sûr, le Samsum, Ant, c'est une appellation maintenant que vous trouvez sur Internet, d'après la publication, celle-là et les autres. Mais en fait, ce n'est pas moi qui l'ai inventé, ce sont les locaux, les autochtones. Ils l'appelaient Samsum pour l'arabe. Samsum, ça vient du Sam. Sam, ça veut dire poison. La fourmi empoisonneuse. Donc Samsum, Ant. Samsum, Ant. L'étude donc, qui a été publiée dans le Lancet, j'avais sélectionné 40 malades que j'ai vus à l'hôpital Tawam, donc, qui présentaient des réactions systémiques à cette fourmi. Puisque l'extrait de cette fourmi n'était pas disponible, j'avais jugé bon de faire les tests cutanés au fire ant, au Solenopsis invicta que je vous avais vu, et les IgE spécifiques donc à cette fourmi avec les IgE totales, qui, à mon avis, n'ont pas beaucoup d'intérêt, généralement parlant. Cette étude a ouvert la voie à l'étude plus détaillée, plus complète, qui fut publié en 1995 dans le journal, dans le JACI. Je dirais un mot du rôle respectif des collaborateurs. Donc moi, mon rôle, c'était de sélectionner les malades, de faire l'allergie évaluation, le bilan allergologique à l'hôpital, c'est-à-dire les tests cutanés, le questionnaire, bien sûr, et faire un prélèvement sanguin, enfin pas moi, le laboratoire, afin de retirer le sérum qui fut ensuite envoyé à Paris pour faire les IgE spécifiques, cette fois-ci au Samsung, parce que nous allons pouvoir fabriquer l'extrait. Le professeur Francis Clénadier, je ne sais pas, il n'est pas français ici, ils doivent le connaître s'il y en a. Maintenant, il est à la retraite. Il est venu à Beyrouth quand j'étais président de la société en 1998. Le professeur Clénadier et le docteur Guérin, leur rôle était de fabriquer l'extrait allergénique et de faire les IgE spécifiques sur le sérum des malades et des contrôles que j'avais envoyés de l'hôpital Tawam à Paris. Un petit historique, le docteur Guérin était le PDG de Stallergen, que vous connaissez sans doute pas. Et en 1987, il avait créé son propre laboratoire. Il a eu une différence avec la boîte, avec Stallergen. Et il avait créé sa société qui s'appelle Allergy. Malheureusement, quelques années après, juste à la fin de cette étude, à peu près 6 mois à la fin de cette étude, il a eu un accident de voiture et malheureusement, il est décédé en France. William Banks, le 4e collaborateur, c'est un entomologiste, spécialiste du fire ant, de la fourmi américaine. Il travaillait dans le département d'agriculture de l'État de Floride et donc il était spécialiste de la fourmi américaine qui faisait des allergies aux États-Unis. J'avais jugé bon de le faire venir, puisque c'était un entomologue, et puis spécialiste d'une fourmi qui fait des allergies. J'ai trouvé judicieux de le faire venir, et il est venu. Donc l'étude, l'endroit, c'était l'hôpital Tawam où je travaillais, voilà, il est toujours là. Ça comprenait donc bien entendu le groupe des malades j'avais sélectionné 31 malades qui avaient eu des réactions systémiques à cette fourmi que je ne pouvais pas encore appeler anaphylactique. C'est pour cela que j'ai mis encore systémique généralisé. La condition première, bien entendu, qu'on était sûr que le coupable était bien la fourmi Samsung. Que la réaction, deuxième condition, devait arriver dans les minutes qui suivent, maximum 90 minutes après la piqûre. Troisième condition, au moins une réaction généralisée dans les 12 derniers mois. Dernière condition, la réaction devait nécessiter une admission au service d'urgence d'un hôpital. Bien entendu, je passe les détails, éthique committee, etc. On avait fait ça vraiment, c'était un hôpital de standard américain, c'était géré par une compagnie américaine, et il fallait, quand on faisait des études, c'était exactement comme si vous étiez à Boston ou n'importe, ça passait par tous les comités, ethics, etc., etc. Je passe ces détails. Les contrôles, le groupe B, 12 volontaires qui étaient piqués par cette fourmi, mais sans réaction généralisée, avec seulement une réaction locale. Groupe C, des 10 volontaires qui n'ont jamais été piqués par cette fourmi. L'âge, le sexe. L'âge, pas de différence entre les trois groupes, environ 36 ans. Le sexe, prédominance féminine pour la simple raison que les femmes étaient, du fait qu'elles travaillaient moins que les hommes dans ces pays, enfin travaillaient, disons, elles restaient plus à la maison. Donc ces fourmis adorent les maisons et particulièrement la cuisine, là où il y a des débris alimentaires pour s'alimenter. Donc les femmes, tout simplement, prédominance féminine parce qu'elles étaient plus exposées. Les fourmis. Monsieur Bank, donc, était venu, il est resté 2 semaines, il a séjourné à l'Intercontinental Hotel de la ville d'Al-Ain, très charmant hôtel. Il a ramassé 17 170 fourmis du jardin de l'hôtel, ce qui faisait 41 grammes. Ces fourmis, tous les soirs, je passais, je les collectais. Lui, il les collectait dans des tubes. Moi, je prenais les tubes fermés. avec un petit peu d'air pour qu'elle reste vivante. Enfin, c'était sa technique à M. Banks. Moi, je prenais ces fourmis, je les mettais au congélateur de l'hôpital Tawam à moins 70 degrés. Congelées, vivantes, comme vous savez, pour les protéines. La préparation, alors ces fourmis, une fois congelées, à la fin de la mission, 2 semaines après le début, donc quand le tout était ramassé, c'était une logistique assez compliquée, DHL, ambassade de France, à Abu Dhabi et ministère de Santé des Émirats. Le ministère de Santé, son rôle c'était de faciliter le passage à l'aéroport afin que les douanes émiraties n'ouvrent pas le paquet pour ne pas dénaturer les protéines. Les douanes françaises, il ne fallait pas qu'elles ouvrent aussi le paquet afin de ne pas les dénaturer. DHL avait promis de faire arriver le paquet moins de 24 heures après, depuis le congélateur de Tawam jusqu'au congélateur de M. Lénadier à l'hôpital Rothschild, et effectivement, moins de 18 heures après, elles étaient arrivées en excellentes conditions. Le bilan allergologique, ça comprenait donc un questionnaire, les tests cutanés, bien entendu. Alors, ils ont fabriqué, bien entendu, l'extrait Samsung, 20 grammes. Ils m'ont envoyé une partie, dans de bonnes conditions, comme d'habitude, entre 4 et 8 degrés. Des tests cutanés, donc, à la fourmi. Et ils ont gardé la deuxième partie pour eux, pour faire les IgE spécifiques sur place, sur le sérum que j'avais envoyé de l'hôpital chez eux, à Paris. L'extrait, donc, les tests cutanés, l'extrait de notre fourmi, j'avais aussi répété encore la fourmi américaine, et bien entendu, le reste positif, négatif, contrôle allergène commun. Et les IgE spécifiques, donc, ça s'était fait à Paris, à la fourmi Samsung. Total IgE, je passe. Bon. Les résultats. Moins de 10 minutes, plus de 3 quarts des malades faisaient leur réaction moins de 10 minutes après la piqûre. 29, je crois, entre les deux ensemble, ça faisait donc 80, plus, à peu près 95%, même plus, dans les 30 minutes. Donc 10 minutes, plus de 3 quarts, 30 minutes, 19%, et une petite minorité, le reste, mais tous moins d'une heure et demie après la piqûre. Donc l'écrasante majorité dans la demi-heure qui suivait la piqûre. Les manifestations habituelles des réactions systémiques de ce genre, respiratoires, wheezing, toux, dyspnée, œdème laryngé, changement de voix, manifestations cutanées comme d'habitude, 90% des cas aussi, pratiquement, urticaire, érythème généralisé, angio-œdème, prurite généralisée, et un patient avait montré des lésions bulleuses généralisées. Neurologique, la moitié des cas, syncope, vertige, vision trouble, maux de tête, appareil digestif, le quart des cas, nausée, douleur abdominale, diarrhée, et des autres, comme conjonctivite, obstruction nasale, fatigue, malaise. Quelques patients ont eu des brûlures mictionnelles, je ne sais pas comment. Et puis quelques-uns, l'impression d'une mort imminente. Les tests cutanés donc, et les IgE spécifiques, on n'est pas surpris. Dans le groupe A, 93%, l'écrasante majorité était positive. 29 malades sur 31. Dans le groupe C et B, pratiquement 3 sur 22, enfin une différence significative. Total IgE, pas beaucoup d'intérêt. Les tests cutanés à la fourmi, pas de surprise. Dans le groupe A positif, dans 55%, donc ça laisse entendre une allergie croisée entre les deux fourmis. Ce n'est pas surprenant non plus. Dans le groupe B, ça n'existait pas. 3 sur 22 seulement avaient des tests cutanés positifs. Conclusion. Donc, ces réactions systémiques à la fourmi Samsung étaient bien anaphylactiques, étaient bien médiées par les IgE. Deuxième conclusion, il y a bien une cross-reactivité entre notre fourmi et la fourmi américaine. Petite présentation, voilà sa carte de visite. Il mesure 5 mm, monsieur Samsoum ou madame, je ne sais pas, on n'a pas vu le sexe ici. 5 mm de longueur, 2,5 mg de le poids. Il chérit les régions ensoleillées, en ville, vous le trouvez en ville, partout, là où il y a de l'habitation, dans les maisons et dans les jardins. Les nids sont très étendus d'après M. Bolton, et ça comprend plusieurs, M. Bolton donc du British Museum. Chaque nid comprend une centaine de fourmis travailleuses avec une seule reine, comme d'habitude. Il avait une réputation d'agressivité. Je n'ai pas trouvé le cas. Il ne m'a jamais piqué dans mon jardin, ni les enfants. Enfin bon, il en avait dans mon jardin, mais il n'avait jamais été piqué. Nous évitions, bien entendu, un petit peu la piqûre est extrêmement douloureuse, et ça, M. Banks, donc l'Américain qui est venu chez nous, l'entomologiste, il était peut-être la seule personne au monde, il a eu le privilège d'être piqué par les deux. Donc il a pu comparer, il m'a dit qu'il a été piqué bien sûr par la fourmi américaine, le fire ant, et par la nôtre, et trouvait que la nôtre était beaucoup plus douloureuse. Par contre, la nôtre ne laissait pas de signature. Entre parenthèses, la douleur persiste, douleur vive, d'après les malades, persiste pendant environ 4 heures, douleur très vive. Alors, la fourmi américaine, la piqûre est moins douloureuse, mais elle laisse une signature, une pustule, quelques jours après, alors que la nôtre, elle ne laisse pas de pustule. C'est un problème de santé publique dans les pays du Golfe. Nous avons des rapports récents, depuis une dizaine d'années, de l'Arabie saoudite, de l'Iran aussi, ça dit que le problème existe, quelques cas cliniques, quoi. Enfin, ça prouve que le problème existe dans d'autres pays du Golfe et en Iran. Il y a aussi une autre fourmi en Australie qui fait quelques problèmes, mais ce n'est pas du tout une ponérine, c'est encore un cousin lointain, et une fourmi aussi en Corée. Bien sûr, Corée du Sud, parce que la Corée du Nord a d'autres chats à fouetter, et elle s'occupe de problèmes bien plus, à leurs yeux, bien plus importants que ça. Les défis, eh bien, la prévalence de cette fourmi jusqu'à présent n'est pas connue. L'analyse de venom n'est toujours pas faite, et surtout, l'extrait allergénique à des fins diagnostiques et surtout thérapeutiques n'existe toujours pas. C'est un monsieur qui est venu, bien sûr, quand on a fait l'étude, ça a fait quelques remous, et tout le monde entendait parler, etc. Alors, ce monsieur, il est venu, et il m'a dit, vous êtes le docteur qui s'occupe de l'étude sur la fourmi Samsoum? J'ai dit oui. Il m'a dit, venez avec moi, docteur, venez. C'est très, très sympathique. J'ai dit où? Il m'a dit, juste en dehors de l'hôpital. On est sorti. Il va vers les Samsoum. Il me dit, voilà, vous dites que ça provoque des morts. Est-ce que c'est le cas? J'ai dit, mais laissez-la, elle va vous piquer pour la douleur. Il m'a dit, ah, c'est vrai que la piqûre est douloureuse. Mais ça ne tue pas, vous dites, etc., etc. Alors, allez lui faire expliquer que l'allergie ne frappe pas tout le monde. Ce n'est pas comme les vipères, ce n'est pas comme le scorpion. Il fallait lui enseigner la médecine, peut-être, et pourquoi pas l'allergologie. Tâche qui n'était pas aisée. Et je termine sur ce portrait. Ce sont des gens vraiment aimables, sympathiques et surtout authentiques. Et je vous remercie.
Merci, Dr. Deep, de cette présentation intéressante qui retrace l'histoire de la fourmi Samsoum. Et nous passons maintenant à la troisième présentation.
There is one thing I realized coming to Beirut or to Lebanon. I can understand medicine in French. Because I go to Quebec usually in Canada, and I listen to some presentations there, I cannot understand a word of what they are talking about. So it's better French here, I think. So this is a picture actually from the last time I was in Beirut. I haven't been out yet this time to take any pictures. But I'll go around tomorrow. So we'll talk a little in the next kind of 25 minutes, talk a little about anaphylaxis. and it flows well from what we were discussing before, all this sensitivity to venom from Hymenoptera venom, since the main, obviously, problem, the more severe problem that they develop is anaphylaxis. People develop from that is anaphylaxis. So just starting very kind of generally, so it's a serious allergic reaction. We don't say much, we all know that. It's a very rapid onset and may cause death. Now, about a couple of years ago now, the World Allergy Organization published some guidelines for assessment and management of anaphylaxis. And they were published in the Journal of Allergy and Clinical Immunology and also at the same time in the World Allergy Organization Journal. And it's a very extensive document. It's a very interesting document. I think it summarizes well what's known about anaphylaxis and what has to be done. And the first author, Estelle Simons, she's actually from Canada. So, I'm here to present some of what she put in this paper. And kind of big part of what I will present really comes from this paper and some references from the paper. So, clinical criteria for diagnosis of anaphylaxis. So they gave 3 kind of different criteria to diagnose, depending on how much we know the cause of anaphylaxis in these people. So somebody shows up without any previous history, without any idea of what they might be allergic to. So what's the condition that you might call anaphylaxis? So it's an acute onset, minutes to several hours, with involvement of the skin and the mucosal tissues, or both of them, and at least one of the following. So somebody has respiratory compromised, or reduced blood pressure, or associated symptoms of organ dysfunction. So it's a generalized condition affecting a lot of different organs and leading to severe dysfunction that can lead to death. Now, if we have an idea, if there is a likely allergen, we know that somebody has a sensitivity to bee stings, but he never had anaphylaxis, for example, before. So we need 2 or more of the following to occur rapidly, again, minutes to several hours after the exposure to diagnose anaphylaxis. So again, it's involvement of the skin and mucosal tissue, respiratory compromise, reduced blood pressure, and persistent gastrointestinal symptoms. Again, a generalized disease affecting more than one organ and having some idea of what the cause could be. And if we have even more information, so if we know what the known allergen could be, for example, we know that somebody had a severe reaction to peanuts before and they just ate peanut by mistake, then it's really reduced blood pressure after exposure to a known allergen. So just blood pressure drop without seeing anything else when we have a good idea of what we expected to see could be enough to diagnose anaphylaxis. In infants and children, we want to see low systolic blood pressure, depending on the age, so that can change for the age, or at least a more than 30% decrease in systolic blood pressure from their kind of resting blood pressure. In adults, less than 90 millimeter or more than 30% decrease again from the baseline blood pressure. So what are the most common causes of anaphylaxis? We know that medications can do it. Antibiotics are probably the most common, but anaphylaxis can happen with a lot of different medications and for a lot of different reasons, both immunologic and non-immunologic reasons. Insect sticks that we talked before about this, and foods. These are probably the most common cause of anaphylaxis. Probably that's the order of frequency when we talk about adults. In kids, foods are probably the main cause for anaphylaxis, much more common than any of the other causes. And then we have, as we all know, other causes of anaphylaxis, less frequent, but could be equally severe. We have exercise-induced anaphylaxis. We have what we call also, and I always kind of mix the term, and I'm not sure how to say it, exercise-induced food-dependent anaphylaxis, or kind of, it's a complicated thing to just say it, but it is, you eat a certain food and then you exercise and you develop anaphylaxis. We have patients that we talk about idiopathic anaphylaxis, so we have often patients that we don't find a specific reason for anaphylaxis. We know that some of these patients, sometimes they are not diagnosed early, quickly enough, and they might have mastocytosis. Again, as we talked a little before, this systemic increase in the number and the activation potential of mast cells. And I have here the latex anaphylaxis. It was a big thing for a long period of time. At least in North America, we almost not see it anymore. I haven't seen somebody sensitive to latex for years now in my clinic. We use very little latex anymore. It's not exposed any in kind of occupational environments. Most of our hospitals are latex-free, so we don't see it. I don't know if you see any of that still here, or I don't know how prevalent it was here also when it was a big thing in North America, talking about latex allergy all the time. They still, actually, we built a new clinic opened about 6 months ago, and they wanted me to have a big protocol about preventing latex anaphylaxis when they hadn't done anything else about preventing anaphylaxis to other more common things. They give antibiotics all the time there to people that are sensitive and they don't care about, but they care about latex. I mean, some things stay in the subconscious of people, I think, and they can never get over it and kind of do the most common things. So what's a differential diagnosis? It's quite wide. There are a lot of different conditions. That's again from the review, but I just put kind of a few of them together just to look. And we all know, I mean, panic attacks, we have to make sure that it's really anaphylaxis and it's not something different. A panic attack could often mimic anaphylaxis. Vasovagal reactions can mimic anaphylaxis, syncope, any other vasovagal reactions. Flushing syndromes from carcinoid, from alcohol consumption, excessive alcohol consumption, a lot of other conditions. Generalized urticaria when there is no other symptoms. It's very often can be kind of diagnosed as anaphylaxis, especially I see it often from the emergency rooms. We get this diagnosis that somebody had anaphylaxis and it is that they had urticaria and they felt a little dizzy because they were scared probably from that or some other reasons to get some dizziness, and without kind of a good history and a good examination, the people are labeled as anaphylaxis. And obviously there are other conditions that kind of mimic anaphylaxis, whether it's hereditary angioedema, where you have big swelling, and if that compromises the airways, because it's a swelling in your throat, it's easy to have also respiratory compromise and really think that it's anaphylaxis. Excess histamine release for any other reason, and also a lot of different kinds of shock, whether it's hypovolemic or it's cardiac shock, that's really not anaphylactic shock in nature, so we have to make sure that we see, kind of analyze the condition well and see if there is any other reason for somebody to have these symptoms. Not a lot of diagnostic tests, it's really a clinical diagnosis. And different kind of publications and even the review kind of talks about the usefulness of serum tryptase or histamine. It has to be obviously collecting the serum soon after the anaphylaxis, so really in the emergency room if the patient shows up in the emergency room. Otherwise, if they treat themselves at home or if it goes away and they show up the next day, it's very little we can do about that. But the problem is that even normal levels of these mediators do not exclude the diagnosis of anaphylaxis. Probably maybe about 30%, they might not have elevated tryptase levels. Tryptase levels are useful more in patients that have anaphylaxis from insect stings or from medications. It's much less useful for patients that get it from foods. It seems that less % of patients with food-induced anaphylaxis have a big bump in tryptase level that kind of gets off the normal levels. And also it's more common in patients that develop hypotension with anaphylaxis, but less common in patients that have other symptoms that don't involve hypotension. It might be more useful actually as not only as a one-off test that we do during the anaphylaxis, but comparing this test with a basal level. So if we had the basal level before and we see a big increase during the episode, we are much more confident that this is anaphylaxis. Or after the anaphylaxis, repeat it and see what the basal levels are, because if the basal levels are also increased, then there is always the possibility of mastocytosis. That's something, although rare disease. Since most of my training I worked with mast cells, I always talk about mastocytosis and I always think about mastocytosis. I think I've done hundreds of tryptases in people and I probably diagnosed 1 or 2 people, since it's not a very common condition, but it's something that we have to keep in mind. Immunologic mechanism, it's generally is a very simple immunology of how anaphylaxis develop. So we have any of these triggers, a person is sensitive to these things, develops IG against these triggers. IG is on the mast cells or the basophils. You see the antigen again, you activate your mast cells, your basophils, you release histamine, leukotrienes, tryptase, prostaglandins, a lot of other mediators, and they cause all the classic symptoms we see. Increased vascular permeability, bronchoconstriction, vasodilation, and all the other symptoms. Now, if we go into more kind of specific, on the left side is the classic way that we talk about anaphylaxis. So it's a mast cell here, but it could be also a basophil that can cause similar symptoms. Activated releases histamine, platelet activating factor. All the other mediators are not there, but a lot of the other mediators also can cause the symptoms of anaphylaxis. We started identifying it first in animal models, where the first observation was that if you get a mouse, you can make the mouse induce anaphylaxis in the mouse. But then you get a mouse that doesn't have IgE, or you get a mouse that doesn't have mast cells, and they develop the same kind of anaphylaxis that the mouse that have IgE or mast cells develops. So there seems to be a different mechanism of anaphylaxis that can happen through IgG receptors. It's not very clear how extensive and how important it is in human, although there is some indications that it can happen also in humans. And there are some people that try also to identify criteria, kind of the expression of IgG receptors and the change on IgG receptor density after the episode, but there is not good data to really know whether that's what it is, or we haven't found the IgE, or we don't know what the specific trigger for anaphylaxis was, so that's why we don't find the IgE-mediated mechanism in humans. However, as I said, from animals we have good evidence that that might be happening. Anaphylaxis-related mortality. We don't have a lot of data. Studies are not very easy to do. It's an anti-reporting. As we said also, talking about bee stings, probably more than half of the people that develop anaphylaxis is the first time they develop it. They don't know what it is. They might not know if it's anaphylaxis. And sometimes it's not even diagnosed well in the emergency departments when people show there. So estimated incidence from some studies, 1 in 800,000 in children, 1 in 4 million in adults. So it's a rare thing, but it happens. And when a retrospective study of 32 cases of food-induced fatal anaphylaxis in the US showed that it's more common in younger people, adolescents, young adults, and big number of it, fatal anaphylaxis, when it's come to foods, obviously, is from the foods that we all know. Peanuts and tree nuts seem to be a more kind of allergenic foods when we go past the very young pediatric age. Now, the most important risk factor really is delayed administration of epinephrine. We know that the primary treatment for anaphylaxis is epinephrine. We tell our patients, we give them the auto-injectors at home, and often people that die is the ones that don't use their medication or take a long time to go to the emergency room to take the medication. And the other big risk factor is presence of asthma, especially if it's poorly controlled. Most of the people of anaphylaxis, again, die from the respiratory symptoms than the other symptoms, and the respiratory symptoms are worse when somebody has already asthma and their asthma has been poorly controlled to begin with. But, as we said, highest fatality rates in patients that don't take epinephrine, or they don't take it on time. It's the drug of choice of anaphylaxis, available in auto-injectors, simple to use, reliable results. There are a few options these days. We have 3 options in Canada. I don't know how many auto-injectors you have here. And it can reverse hypotension and bronchospasm. No absolute contraindications to epinephrine in the setting of an anaphylaxis. Even older people, they might have cardiac problems or anything else. I guess it's better to save them from dying right then and see what happens with their heart than let them die there and then they never develop any more heart problems, but they are dead. And antihistamines should not be the first-line treatment for anaphylactic reactions. They are useful, we use them, but it's not what will save somebody when they develop anaphylaxis. Just a quick kind of table with the different drugs and what they do. We talked a little about epinephrine. We can repeat it every 5 minutes to every 15 minutes until the resolution of the symptoms. Very often, patient will need more than 1 dose of epinephrine. And also we know that very often the anaphylactic episodes could be biphasic in nature. Somebody might recover, have no symptoms, and a few hours later develop a second phase of anaphylaxis. Like glucagon could be useful when people that do not respond to epinephrine, and especially in certain population of patients that take kind of certain drugs, especially beta blocker. Salbutamol bronchodilators can be very useful to reverse the respiratory symptoms, but again, it's not the first line of treatment. Unless we think that it's really an asthma attack and not an anaphylaxis, we have to use epinephrine as a first line of treatment, and if there are still respiratory symptoms, we can use also salbutamol. Antihistamines, whether it's H1, H1 plus H2, it's probably something that is an adjunct treatment. We can give it and can decrease some of the symptoms, but it's not the first line of treatment. And corticosteroids, like in a lot of these conditions, can decrease the late symptoms of anaphylaxis, so kind of the chronic inflammation that develops after an acute inflammatory reaction, Again, they will not save somebody from anaphylaxis when it develops, but they might decrease the long-term morbidity from the anaphylactic episode. I will not go much through these things. So this review that they had, the guidelines, and a new review that Dr. Simons also wrote, has a kind of description of what's the treatment for anaphylaxis. And it is, in general, what we said. So people have to remove the exposure. So, for example, if it was a food, they don't eat anymore. If there was something else, they have to get away from this exposure. We have to assess their respiratory status and their oxygenation status and deal with those things right away. We have to call for help, unless we are in the emergency room and we are the help. If it's somewhere outside, we have to call for help. We give epinephrine, that's the important thing. And then all the other measures by putting people on their back, give oxygen if it's required, establish an intravenous access and use fluids if there is hypotension. If we need to perform cardiopulmonary resuscitation because the patient has stopped breathing or the heart has stopped, and then maybe they need frequently repeat of epinephrine. And what should we do after an anaphylactic episode? Obviously, we have to try to determine the cause of anaphylaxis. And in some cases, it might be known. So if it's a second episode of anaphylaxis, we might know what it was. So then we just have to reinforce with the patient take better measures to avoid another episode of anaphylaxis. But if it's the first time that it happened, then we have to get a careful history and diagnostic testing if we think it's helpful to identify what's the cause. Referral to an allergist is important, and that happens a lot. Although I get referrals from the emergency room, there are quite a lot of people that go to the emergency room and they never send to an allergist for further testing. And I have had patients that showed up a long time later and they said, I went to the emergency room, they told me, what did you eat half an hour ago? That was the cause, don't eat it again. It's possible that that's what it is, but that's not a diagnostic test to figure out really what happened to a patient. In most cases, probably it's not that, unless they have a history, obviously, of allergy to this food. And then we have to educate the patient. Information about how to avoid the precipitating allergen, if we can identify the allergen, food avoidance, insect sting avoidance, antibiotic avoidance. Prepare a comprehensive anaphylactic action plan. Especially with kids, it's also a big issue. Prepare the family to have a plan. Prepare the school to have a plan. If anaphylaxis develops at school, what to do with the kid. Demonstrate to the patient and the family, especially when they are kids again, how to use the auto-injectors that we give them, and educate the patient of how to read the food labels. When it talks about food allergy, it's very important for prevention. It's probably the most difficult one to prevent because a lot of foods are hidden in between other things, and sometimes it's difficult to know what's in some of these prepared packaged foods that we buy. And obviously, there are some community patient support groups, and information and connecting the patient with these support groups, it's also very important if these groups are available. So one study tried to find what's the emergency department gap. So what's done wrong in the emergency department? A lot of these patients, especially after the first anaphylaxis, they will not come to an allergist right away. I mean, we are really far from seeing us when it's the first time. So somebody has to connect them with one of the allergists, give them first the right treatment, and then connect them with an allergist to make sure that we can diagnose the condition. So patients with systemic reactions, mild or anaphylaxis in general. So this study showed in the US that about a third, maybe 40% were given instructions to avoid the allergens when the allergen was known, obviously. These are patients that they knew the allergen and they were not really given any more information after they failed to recognize the allergen before. About 14 to 20% of all of them received only a prescription for epinephrine. So they had diagnosed anaphylactic episodes. They knew or they didn't know what the cause was, but they were not given an epinephrine when they went home. Less patients, 10 to 15%, were actually referred to an allergist, and only about 2% actually had all these things done, that we think that all these things should be done for each one of these patients. And also, even though they were diagnosed with anaphylaxis, maybe it was milder, but then only about a quarter of these people received epinephrine in the emergency department. Even the emergency department, often the treatment of these patients is not optimal. And I will finish with a study that was published last year. I find it very interesting because it makes a few kind of interesting points. It's not necessarily about anaphylaxis, the whole thing. But it was a longitudinal study, prospective study of kids with documented or suspected allergy to milk and or to eggs. So about 500 kids, they followed them for 5 years, and these kids developed a lot of reactions. So 367 of these 512 kids developed reactions. About 270 of the kids had actually more than one reaction. So they give the rate of reaction, 0.81 reactions per year in general, 0.34 per year for milk, 0.17 for egg, and 0.06 for peanuts. So these kids develop quite a lot of reactions, and about half the kids develop more than one reaction within 5 years. And then they separated the reactions. They called them mild, the lower part, moderate, and the darker part is the severe reaction. Severe reactions are not necessarily all of them anaphylaxis, but a lot of them were anaphylactic reactions. And the severe reactions to food happens primarily with ingestion of the food, very rarely, very few reactions with exposures to the skin, and almost never through other routes. I get a lot of patients that come and they think they are allergic to foods and they develop anaphylaxis, even they tell me, because they smelled the food in a restaurant or they smelled the food that somebody else was eating 3 tables down. We don't think it happens. Some of these studies don't show that it happens. You think it happens? It's tough. I haven't seen any documented one that I can document it. I mean, it is possible that it would happen, I guess, but it would be a very rare thing. In kids, in this kind of large study, they didn't find any of those. But when I found even more interesting is that, so these kids had 1,171 reactions. 134 of those reactions were severe enough, but only 30% of those epinephrine were used. So then they went back and they asked the caregivers, why didn't you give epinephrine? What was the problem? They were all kids that had actually epinephrine. And 50% of them, they didn't recognize the symptoms, so the caregivers of the kids could not tell that the kid had anaphylaxis, although they ended up in the hospital and the kid was diagnosed with anaphylaxis. About a quarter, there was no epinephrine available, so they had a prescription, they knew they should have it, but they didn't have it with them. And about 12.5% were afraid to use it, so it was there and they didn't use it because they were afraid and they ended up in the emergency room. So we have a long way to go to educate people with anaphylaxis that they should have their epinephrine. Epinephrine can save their lives, and they should use it when something happens. So in conclusion, immediate recognition of symptoms and institution of appropriate care is vital in cases of anaphylaxis. Epinephrine is the drug of choice for anaphylactic episodes. And follow-up with an allergist to identify the offending allergen is required in all cases of anaphylaxis. Thank you.
Thank you, Dr. Vilogoftis, for this update on anaphylaxis. It was quite interesting, and now we were going to take some questions, if there's any. Dr. Irani.
Thank you, Harry. It was very interesting. We don't have auto-injector EpiPen here, unfortunately. So what we do is either give a prescription, they get it from Europe, or we give them adrenaline and they mix like in the syringe. And unfortunately, this is a major problem and we need more education on this problem, because many of our anaphylactic patients, they were given prescription for corticosteroids to keep with them, thinking that it will save them from death. So this is a very important public health issue that we have here and not yet addressed.
I mean, it happens also in Canada. I don't know if you saw any patient in Canada. I get patients that show up and they have a prescription for steroids, or they have steroid with them and they pop a prednisone when this thing happens, and probably doesn't do much, and they are lucky that the worst things don't happen.
Yeah.
I have a few patients that actually have also epinephrine and a vial and they use it. I have a couple of patients that they use it very often. I was not happy to give them the epinephrine instead of giving them auto-injector, but it's very expensive, the auto-injector is also there. Some people don't have coverage in Canada. So I have a couple of people that have the vial of epinephrine, because I have one of them that uses epinephrine probably a couple of times a month. And we haven't figured out what's wrong with her, but she definitely gets anaphylactic episodes. It looks like idiopathic. We haven't figured out anything, but...
I have another question about immunotherapy for bees, because some studies showed that 50 microgram may be enough because they had less severe reactions. I don't know. The recommendations now are 100.
The recommendation is 100 as far as I know, and what I've seen, a few studies that I went through this time, everybody seems to recommend the 100. That's what I have been doing. I don't do a lot. I don't have a lot of patients with bee venom allergy. They're not... It's cold enough that even the bees live from Alberta, I guess, so we don't have too many of them. So, but we have some people, obviously.
Excuse me. I'm asking if there are any side effects for using epinephrine, EpiPen, like in cases where we are not sure about anaphylactic shock, and some people or children, when they can use it for family or any...
I mean, for young people, I don't think so. I mean, the only thing it will do, it will speed up your heart. It can increase your blood pressure. I mean, older people that might have heart problems, it could be a problem. And if they use it inappropriately, it could be a problem. But for younger people, healthy people, kids, I almost sometimes try to err on the side of use it a little earlier than later. So I tell them, you know, if you think it's anaphylaxis, use it and don't wait and wait, because then, especially if you are alone, if you have somebody with you, you can wait a little longer. But if you are alone, you wait long enough, then it's too late. So.
Thank you.
Thank you.